Good evening and welcome to the first in a series of Master Techniques webinars organised by BOFAS, EdCom and SciCom. This evening's webinar on balancing the ankle in arthroplasty surgery has kindly been sponsored by Exactech. In the first half of the evening, our speakers, Dave Townshend and Andy Goldberg, will discuss their approach to balancing the valgus and varus ankle with practical tips on how they achieve balance. In the second half of the evening, they'll be happy to answer questions from the audience, which you may submit during the presentations. We will attempt to answer as many questions as we can during the session. I would now like to hand over to Dave Townshend to discuss his approach to the varus ankle.
Okay, thank you, Ian, and BOFAS EdCom for asking me to talk. I'm going to start with balancing the varus ankle. So I'm talking to you tonight from my home in the northeast of England. These are a couple of the beaches just north of here, voted in a recent Which survey as two of the most popular coastal towns for you to spend your staycation. My ankle replacement journey started in 2009 as a senior registrar with Malik Sadiq, and then spent a year with Murray Penna's group in British Columbia, and was appointed to the Northumbria Trust in 2010. I do between 20 and 30 ankle replacements a year. Started with the Integra prosthesis and then moved over to the Infinity Inbone system around 2014. So those are the implants that you'll see in my slides, but obviously other implants are available. So varus deformities are relatively common, and unfortunately moderate to severe deformities are common, and much more so than our knee arthroplasty colleagues would see. The issues with ankle replacement in the varus ankle are recurrent instability leading to early failure, and residual deformity leading to edge loading and increased polywear leading to failure in the medium term. So one of the questions always asked is, what are the thresholds, or what should the thresholds be for coronal plane deformity? In the early noughties, Peter Wood suggested 15 degrees in his STAR paper, Valdebrano an absolute contraindication of 20 degrees, and then various papers suggesting or commenting that there was increased failure with increasing deformity. As we got better, our thresholds have started to broaden. This paper from Sunil Dar's group in 2009 really started that conversation about ankle replacement in more severe deformity, noting good results if you balance the ankle even up to 30 degrees. Daniels published his instructional paper, which is worth a read, in 2013, showing no difference in cohorts above and below 10 degrees. A study from Lee suggesting that severe varus compared to moderate varus still good results if you balance the ankle. And Malik Sadiq's group have just published this year. This is a slide from the UK Infinity study and just shows you the breadth of deformity that's being tackled. These are 500 ankles across 12 centres. And again, at a year, no difference in the PROMs in those below and above 10 degrees of deformity. So ankle replacement can do well in deformity, but only if you balance the tibiotalar joint and the mechanical axes above and below. So in the talk tonight, I'm going to cover where to look for the varus, strategies for extra-articular varus, intra-articular varus, and hopefully leave you with a logical approach to ankle replacement in varus. So basic stuff, where to look for the varus. You need to look outside of the ankle joint. There's often deformity proximal to the ankle, in the knee or the tibia, and often deformity in the hindfoot. That deformity is quite often a combination of all of these. So with that in mind, I would suggest this is a minimum radiological data set, long leg alignment views or CT scanogram, standing AP lateral of the ankle, obviously. Standing AP foot will tell you about adduction at that talonavicular joint. You may want to think about tib post lengthening or a talonavicular joint release. This is the hindfoot alignment view, which will also tell you what the subtalar joint is doing beneath your ankle. and we would routinely now get a CT. So for extra-articular deformity, you decide whether you're going to tackle this as a single stage or two stage. That's largely going to depend on your surgeon confidence, what you feel able to do within a reasonable tourniquet time, so the number of additional procedures you need to perform, but also consider, do you or can you delay or defer the second stage? So will this a realignment procedure actually give the patient enough symptomatic benefit? So we'll look at some cases. This is a 68-year-old gentleman who came with a varus left ankle. He's got that translational type of arthritis with a congruent joint and loss of the medial gutter. And in these ankles, you need to be looking more proximally. His long leg alignment view, he's got a varus knee. This was asymptomatic, so we talked to him, our knee arthroplasty colleagues, and within the MDT, and we agreed that if there was going to be any surgery, it would need to be a knee replacement. He had his knee replacement. Here's his mechanical axis, his anatomical axis corrected. He saw resolution of his ankle pain within about 6 months. And here he is 6 years later with minimal ankle pain and certainly no intention of proceeding to any ankle surgery. Here's a slightly more severe varus. This is post-traumatic after a tibial fracture 20 years ago. An ankle replacement in this is going to be unbalanced. So we went to a supramalleolar osteotomy and an ankle replacement, which we were able to delay by 4 years because she saw enough symptomatic relief from the osteotomy. Here's a slightly older gentleman with a varus limb, so congruent varus ankle arthritis, varus knee arthritis, and quite significant tibia vera. He had knee replacements for symptomatic knee arthritis. The decision then for his right ankle when he came to surgery was, would we realign him as a stage procedure or align him to his mechanical axis with a primary ankle? Given his age and his desire for a single surgery, we used the prophecy planning to align an ankle implant to his mechanical axis. And here he is needing a fibula shortening osteotomy to balance that ankle. And he's done well for 2 years. I saw him a couple of weeks ago. He has got a bit of medial pain, which we need to keep an eye on. Here's a patient with Pes Cavus deformity. Again, an ankle replacement here would be unbalanced. So he had a staged Pes Cavus correction, so a peroneal tendon transfer, ligament reconstruction with internal brace, calcaneal and first metatarsal osteotomies, and a staged ankle replacement. That was about 6 months ago, and he's doing well with a balanced ankle above a balanced foot. So in the joint itself, at the early part of my career, I was really just thinking about the tight medial structures and then tightening things up on the lateral side. And I wasn't appreciating this lateral block. If you look at varus ankles, you'll often see this lateral blocking osteophyte and remodeling of the lateral gutter. And you need to address this to address your varus deformity. Here's a case with a lateral osteophyte. In the top left, you'll see a separate incision to address this, and I commend that. On the right, that's an image simply after removing the osteophyte, and you can see the amount of correction that's achieved without any medial release. My medial release is sequential, a laminar spreader into the joint, assess the bone defect. Often that's all that's required to correct the medial side. If not, I'll address the osteophytes first, then release the deltoid from the talus with an osteotome. If that's not sufficient, then I'll peel everything off the medial malleolus right the way around to the back. I'll often now do a tibialis posterior lengthening to complete the correction. A medial malleolar osteotomy is a useful technique to have in your armamentarium. This can either be a vertical slide described by Dirtz or the oblique, which is what I would routinely use. This has the advantage that if there's remodeling of the medial malleolus where the ankle has come out and internally rotated, there's often a defect there, and this will fill that defect. Here's that case I showed earlier, medial malleolar osteotomy to bring that medial malleus down, lengthen the medial tissues, and rotate in to fill that defect. You fill the osteotomy with bone graft and held with 2 screws, and I would fix that after I've put my implant in. And here's that patient a year later, with a well-healed osteotomy and a balanced ankle. Lateral ligament stabilisation. I rarely do these now in a primary ankle. The implant I use is constrained, and I think a brostrum probably isn't enough if there's significant ligament instability. And that's been mentioned by a number of authors. So if there is significant instability, I will go to a modified Evans tendon transfer. But I don't think I've ever done that in a primary, but I have in revision situation. Calcaneal osteotomy, we do this at the end of the procedure to balance any residual heel varus. Again, I'm doing much less than I used to, and I think that's because I'm getting my talar implant in the right place, aligned to the anatomical axis. If I do a calcaneal osteotomy, this lends itself very well to a minimally invasive technique. So I'll finish with this failed ankle replacement that I showed in the first slide. So this was a 6-year-old gentleman who had a primary 7 years ago for post-instability arthritis. He had some residual instability and underwent a lateral ligament reconstruction, but presented last year with increasing deformity and pain. Here's his prophecy patient-specific implementation planning, and I've put this in because you can see, particularly on the left, with the talus reduced, there's significant overlap of the fibula and the talus, and all of that bone needs to come out in order to get that talus in its correct position. In the center, you can also see that the talus has originally gone into a slight malposition, contributing to that deformity. So the revision plan, remove the implants, debride the lateral gutter as a first step, a medial release with or without an osteotomy, and then a lateral ligament reconstruction, which in this case would be a modified Evans if required, and then prepared to do a calcaneal osteotomy. And we felt happy that we could do this in a single stage with 2 surgeons. Here's his images. This was about 6 weeks ago. So 2 screws over a spiked washer for the Evans, and didn't need a calcaneal osteotomy with the talus in its anatomical position. And you can see that lateral gutter completely cleared out, allowing the talus to relocate. So there's increasing evidence and experience to support ankle replacement in the varus ankle, but you need to be confident with your additional procedures. Consider staging these, and hopefully you now have a stepwise approach to balancing your varus ankle. Thank you.
So that's Dave's excellent algorithm on how to deal with the varus ankle in ankle replacement. Now I'd like to hand over to Andy Goldberg from London, who we all know well, for his dissertation on how to deal with the valgus ankle in ankle replacement surgery. Over to Andy.
Thank you, David, for an excellent rendition on the varus ankle. Let's move on now to the valgus deformity. So my name is Andy Goldberg, and I was born in Cardiff, trained at St Mary's, and now based in London. But I did have a trip up to Newcastle to connect us, David, because that's where I, in fact, met my wife. So this is a photographic illustration of how I got into ankle replacements. This is about 15 years ago. I did a traveling fellowship to experts all the way around the world that had developed ankle replacements, and it gave me a fantastic exposure to all of their tricks and tips, seeing various different ways, as well as having tried out virtually every ankle replacement on the market. Now, when I came back with Paul, we set out to edit a textbook called The Atlas of Ankle Replacements, which after all this time, I'm delighted to say has finally come to fruition, with chapters from all of the people that we went to visit from all the way around the world. And it includes an output which is a catalogue really of every implant on the market, including the design rationale as well as all the evidence behind each of them. Now, The important bit, there was a whole chapter, if you like, on the balancing of an ankle replacement. And so I'm going to just sort of reflect that as well as my experience in this talk. And as David pointed out, the important bit is obviously we want to avoid edge loading, and therefore alignment is essentially important. Really, most of the biomechanical work has come from the knee literature. And what we want is that the implants are perpendicular to the weight-bearing or mechanical axis of the limb. And we know that that's about 89 degrees, but it's a very simplistic way to look at that in one plane when deformity is in fact in three planes, especially in the foot and ankle. We know that the center, the mechanical axis, if you like, is the center of the hip to the center of the ankle. Some people say the center of the hindfoot. And in fact, that should go through the center of the knee. The mechanical axis of the tibia, in contrast, is from the center of the knee to the center of the ankle. And the anatomical axis, we draw two spheres along the metaphysis, and the bisection of those is the anatomical axis. And in most cases, those axes all meet up and are the same. But some very nice work from Bernasconi and Ajeffi shows that that's not always the case. In fact, frequently, the mechanical axis of the limb and the anatomical axis are different. So you cannot rely just on an ankle X-ray. In particular, there's also an issue in terms of axial alignment. And so we know that when you plantarflex the foot internally rotates, and when you dorsiflex, your foot externally rotates. But this was a paper, we're looking at ankle replacement, 160 ankle replacements patients prior to their ankle replacement. And what we showed when their foot was plantigrade, that the range of relationship between the foot and the ankle and the knee, in fact, is hugely variable. And there's up to 40 degrees of difference between the foot and the transmalleolar axis in different patients. So that's an important variable to take into place. In addition, cysts, we know that cysts after ankle replacement are a big problem, but this paper shows that about 78% of ankles prior to their ankle replacement have cysts present. And a third of those are greater than 5 millimeters, which is often the definition of osteolysis post-op. And what's more worrying is that 60% of them were not visible on plain radiographs. So when you see an X-ray like this afterwards, you really do need a preoperative image to know whether or not that's a progressive deformity or in fact something that was there before, or both. This all points really to the routine imaging that we do. And this is similar to David's view, which is we'd always do a routine long leg film and a CT scan for planning reasons and for looking at cysts, as we said. But increasingly now I'm doing an MRI scan, largely because the TAVA study, which is a randomized control study of ankle replacement against fusion, showed a significant number of patients that were asymptomatic, had adjacent joint arthritis present on the MRI. In addition, if someone's got severe tendinopathy, for example, the Achilles or the tib post, it's nice to have that information preoperatively so that you can counsel the patient that they may continue to have that symptoms and pain afterwards. And I now pretty much routinely do an MRI as well. But increasingly, there's a role for the standing CT, and now most implants on the market have a patient-specific system that's been aligned to PSI from standing CTs, but increasingly there's a role now for scanning the hip and the knee standing, and the new high-rise scanner from standing CT, in fact, will do hip and knee and probably remove the need for long leg films and a CT scan. And the problem is if you have ankles like these that are, and you don't address the deformity, they fail. Okay, and here's two infinities that fail very rapidly within a year of the ankle replacement. And the evidence, as David pointed out, is pretty clear. You should not be doing an ankle replacement if it's above 10 or 15 degrees. But those papers are based on old implants, and they're also based on, I think, old thinking, because the balancing of the ankles, I think we've got better understanding about it now, and they certainly do have an increased failure. But modern thinking is that the absolute degree of varus and valgus is actually less relevant. And as long as you can achieve after your surgery, no matter how many stages, you can achieve a well-balanced plantar-grade foot, then in fact, most ankles now are fair game to consider a replacement. The very important point, I think, though, that is a distinction between varus and valgus is that varus ankles are invariably stiff, post-traumatic or cavus feet, whereas valgus ankles typically are lax and unstable. And I think that's an important point for you to remember. When I think of an analogous ankle, I think of the deformity at various different levels. I think of it as proximal to the ankle, at the ankle, or distal to the ankle. The classic proximal to the ankle is a genovalgum or verum, or previous hip or trauma, the proximal trauma. At the ankle, you can either think of a congenital deformity or post-trauma, for example, syndesmotic disruption or fibular malunion. And distal to the ankle, think of a cavus or a pes planus. So when we deal with proximal to the ankle, I think there's a key message here is that you cannot fix a problem proximally at the ankle. And I think if you try to do that, you will run into trouble. So here's an example where the knee's an issue, and you have to go and discuss this with your knee colleagues and look either at potentially a knee replacement or an osteotomy proximally either of the femur or the tibia. And the issue is, though, is that some patients have no symptoms. And it's a very difficult conversation when you're saying, well, I don't want to have something done to my knee when it's giving me no symptoms. And that is a difficult problem to solve. And sometimes you can't solve that, but it's important to be aware that you can't fix that at the ankle. And this X-ray here shows why there's no point relying on just ankle X-rays. It looks pretty normal, that X-ray, but that belongs to this image here where there's clearly a proximal deformity. Now, if there are intra-articular issues, there's two very important variables. One is whether or not there is bone issues or whether it's soft tissue issues. And you have to balance the two, okay? If it's a bony issue, like there is in this case, where this is a JCA and she's got an abnormal shape to the distal tibia, you have to deal with this with bone cuts. Okay, and these images here where they're suggesting you can under-resect them and correct them are incorrect because they don't understand the guys that are doing the analysis don't understand the patient issues. Only you understand those. And in this case, if you try to balance this ankle with soft tissues, you'll end up in real dire straits. And this has to be dealt with bony cuts. But if the ligaments are lax, then you've got to deal with them with ligamentous correction rather than bony cuts. So they're two absolute distinct issues. Important to be aware of those two. The soft tissues are very important at the ankle. We've talked about lateral ligaments with Dave and the varus ankle, but the deltoid ligament, including the tibio-navicular and tibio-spring, are having an increased role, especially after post-ankle fracture. Because what happens is they resist external rotation of the talus. And typically, the talus externally rotates and appears to be subluxing posteriorly. And that can happen, especially after trauma such as a posterior malleolar fracture or syndesmotic disruption. But this is an increasing importance. And the most amazing images, as you've seen from Pau Galano from the University of Barcelona, demonstrate the complexity of this ligament. Okay, the deep deltoid goes across two joints, and there's no repair that is able to reproduce this amazing structure that God has given us. There are techniques that you can use, and one of the techniques I'm typically using nowadays is I'm peeling off the deltoid, removing any osteophytes on the medial malleolus and taking it back to fresh bone, and then reattaching the deltoid back on with the hindfoot corrected. And that I find a very useful technique. And I often reinforce that with an internal brace, for example, here, going from the talus and the calcaneum, and sometimes reinforce the tibio spring as well with a further limb coming down to the navicular. So that's one technique you can use. There's also allografts that you can use. This is, I think, a challenging solution. You can either fix it via a screw or via a transosseous tunnel. I think it's really challenging because no matter how wonderful you do this, it doesn't replicate that full band of tissue. So that's why I prefer a sort of a Brostrom equivalent repair, but reinforcing it. And don't forget that lateral instability can also happen in valgus ankles. And I think we often forget that. And I know Dave said that he's increasingly or decreasing his use now of lateral ligament reconstruction. For me, it's the reverse. I think that the more I'm doing soft tissue balancing now, the more I'm realizing the importance of ligament constraints. And when you've removed all the osteophytes on the lateral side, often there's huge instability there. And those osteophytes will often impinge if you don't remove them. And so I now typically remove them and then do either a rostrum repair or a sleeve and bring all of it back onto the fibula. Again, having to freshen up the fibula because often the tissue just lax and is not even attached to the fibula. And sometimes I then reinforce this just like internally with an internal brace, but on the lateral side. And I typically use a two limb technique. So I have an internal brace go from the talus to the fibula, one go from the calcaneum to the fibula, and they both go into one anchor into the fibula. This is important, especially in ping pong ankles, which we're going to come to in a second. Don't forget the syndesmotic instability. Now, some very nice work coming out of the University of Iowa from Cesar Doneto's group is suggesting that in flat feet now, there is chronic disruption to the syndesmosis, and it's gradually tearing and stretching over the years. And that's an important thing to worry about with flat feet. But obviously, there's also the post-traumatic, the post-malleolar fractures and the syndesmotic disruption with a widened mortise, and the talus then tilts inside, and osteophytes form around it, a bit like you find in a hip with circumferential osteophytes. And I think the key here is the hind foot alignment view, because what you can look for here is if the deformities at the tibiotalar joint or at the subtalar joint or both. And you can have a double whammy where the medial structures are attenuated, but also the hind foot is in significant valgus and everted at the subtalar joint. And that is something which I think you've got to deal with. And sometimes a syndesmotic fusion is the right way to go. And I'm increasingly looking at this now as a technique in valgus ankles. And remember, the ankle replacement called the agility ankle replacement, developed by Frank Alvine, in fact, relied on the syndesmotic fusion. So this is not new to ankle replacement. Now, we talk about the ping pong ankle. What is the ping pong ankle? Well, not all valgus ankles occur in flat feet. Now, if you have a severe ligamentous disruption, a syndesmotic injury, then the mortise is widened. And in a cavus foot, the typical talus tilts into valgus, and you have a plantar first ray, and the foot remains plantigrade because of the correction into valgus. And so when you look at the patient from behind, what you find is that their talus is facing outwards like a Z deformity, but the heel is a varus heel. And I think the issue with these patients is that you've got to treat them as a cavus foot, because when you correct the hind foot, the ankle tibiotalar valgus, you will then drift further into varus and a further plantar first ray, and they'll run into problems. So you've got to deal with that and address that at the same time. So don't forget, this is an important group that sometimes sees you, but you may not have seen it. It was highlighted by many authors, in fact, the ping pong ankle, including Steve Haddad and Tim Daniels. Now, when do you stage your ankle? Well, there's no hard and fast rules. I always think about patient factors, their age, their compliance, and comorbidities. But increasingly now, I don't want to be a hero, okay? If you can't do everything in one tourniquet time, then don't do so, because having a big wound problem afterwards is no fun for the patient and a real issue for the patient. And obviously, the most important factor is the vascularity, especially of the talus or of the skin. So if you've got to do 2 incisions, think about the skin bridges. Can you adjust those? And when you're doing, for example, a triple with an ankle replacement, you virtually devascularize the talus. And that's a really important issue, that those are when you must stage them, because otherwise you will end up with AVN. Because remember, primum non nocere, our first rule, if you like, is to do no harm. I won't show you this case because we're going to come to a case study in a second. In summary, don't try and correct proximal deformities with a TAR. You've got to reduce the talus, just like you do with a varus ankle. You've got to debride all those osteophytes. You've got to restore the talus, often by internally rotating. Establish the level of the deformity, and remember that actually sometimes it's more than one level, and sometimes they're counter-opposing each other, like the ping pong deformity. So just remember where the deformity is and what you've got to do to ensure that you can achieve a stable plantigrade foot with balanced powers. Now, I'll just show you one case study that I think highlights both varus and valgus, and hopefully will stimulate discussion. This is a lady with end-stage ankle arthritis and flat feet. This is what she looks like, and this is her imaging, and she's got a huge varus tibiotalar joint, a huge cyst in the talus, There is a proximal biomechanical abnormality, and her knee replacement will put in with slight varus. And so, but that's not major. And we felt that that wasn't, we weren't going to look at revising her knee. So we left those alone, but we have to decide what do we do on her hindfoot. And when you look at the issue here, what she's got is huge peritalar subluxation with arthritic changes at the subtalar joint, a large cyst at the subtalar joint, and a varus tibiotalar joint. So your options, well, you could continue non-operatively, but she didn't accept that. You could do a TAR, leaving the subtalar joint alone, or you could do a heel shift, or you could do a TAR plus a subtalar fusion or a triple fusion, or you could bail out and do a TTC fusion or pantalar fusion. So we discussed this case in MDT, and I think increasingly now with the role of networks, this is an important step to do, and we now run an MDT to discuss cases amongst surgeons, radiologists, microbiologists, physios, etc. And I think that anyone that wants to be to join our MDT, would love to hear from you and to get involved. We chose at the MDT to do a staged procedure. So the plan was to do a triple fusion and graft the cyst. And if the cyst took, then we could do a TAR afterwards. If it didn't, then you could always do a fusion afterwards. So that was the plan. And here's the technical tip, is that you've got to reduce the talus into the ankle mortise before you do your triple. Otherwise, you're going to get into no matter of trouble. And so I do that by reducing it, in this case, externally rotating, doing a medial release, and then putting a K-wire through that so that it was held, and then you do your triple. Okay, and I often use a distractor in the sinus tarsi to correct the massive eversion. So you don't want the anterior part of the talus digging into the calcaneum. You have to create a gap there. I don't get any brownie points for breaking off a drill bit here, but it ultimately achieved what we wanted to do, get her a plantar-grade foot. We then chose to do an ankle replacement on top of it. I used a patient-specific instrumentation, and because the cyst hadn't taken, we chose to use a plate to reinforce that. And so we used an Envision implant as a primary ankle replacement because the cyst really didn't take, and despite grafting it, therefore we chose to put that on. And the result was a nice stable foot. The important bit is clearly worrying about the wounds, and this was a negative pressure dressing that we're now starting to explore its use. And after about 15, 20 cases now, we've had very good results. We also use ice therapy because I believe you've got to really worry hugely about the wound. And the focus is that, and that dictates your mobilization. And because we've done the triple first, in fact, we were able to mobilize it much quicker. And remember, physical therapy is all around core stability, proximal chain kinetics. And I'm not interested really in the ankle at the initial phases. It's all about core. Just to show you the negative pressure dressing, this is called a Provena, but this achieved beautiful wound after 2 weeks. And this is her x-rays now at I think 18 months, and she's doing very well. And the important message there is that you can achieve a plantar-grade stable foot with the powers balanced, and patients are then very, very happy. Thank you very much. Happy to take questions.
So thank you to Dave and Andy for their great talks there, and we've got a few questions coming through on the chat, and please feel free to put them through the Q&A button on your Zoom panel. So the first question is to Dave from our President-elect Paul Halliwell. He says, great talk, Dave. How do you deal with talar dome asymmetric wear?
Okay, thanks, Paul. Yeah, that's a good one. So, so I think I have the advantage now that I'm almost routinely using patient-specific instrumentation, so I can get the talar dome perpendicular to the anatomical axis of the talus. Before I had the PSI, I think a little bit like when you do a knee and you anticipate asymmetric wear, you want to look to check that your talar cut is asymmetric. And probably be wary of that compensatory subtalar valgus. So when you've got your ankle corrected round, if your subtalar joint's already in significant valgus, you need to get it well beyond neutral. And I think finally, it depends on the system that you're using. So the system that we're using, the Infinity, has an option of either a coupled or an uncoupled cut. So I will now do all of my releases, and then I'll do a coupled cut of both the tibia and the talus, whereas some of the other designs are uncoupled. So you have to cut your talus and your tibia separately. So you have to judge, I guess, more your talar cut. But I think, as I mentioned in the slide, I think malpositioning and subtle coronal plane malpositioning of the talus is and was quite common.
Okay, thanks very much, Dave. I'll move on to a question here for Andy now. What percentage of your valgus TARs use staging, and what percentage of your varus ankles use staging?
So I don't think I can answer that, because I don't think it's as straightforward as a percentage. It's I suppose if I can do everything in one go, obviously that's the intention. But if it's a triple fusion or someone's got a flat foot correction, I typically will do that as staged, just a standard, just because I'm worried about the vascularity. And you know, they're recovering for 2 months, 3 months anyway. So actually, by staging, you don't actually change the recovery time for them at all. And typically, I'd do, if I was doing a triple and an ankle replacement, the total time would be exactly the same as just having a triple by itself, to be honest, because I'd do about 6 weeks and then do the second stage and then get them weight bearing very quickly afterwards, and get them going after the ankle replacement. So I suppose the answer is that it depends on the patient and it depends on the level of deformity. But when it's a complex one, I'm much happier now to stage than I was. I was trying to, do things before, and that's where you run into problems. That's when you get complications, and you only need to get one wound infection or one wound breakdown or a deep infection to change your practice.
So you tend to stage it with 6 weeks, stop, and then 6 weeks. You don't wait for it to all kind of become solid and they have rehabilitated from the triple then?
Yeah. Do the triple first usually, so that I can get them going quickly after the ankle replacement.
Yeah. Okay. And are you using those VAC dressings? Is that because you had wound problems, or do you think it's decreases the risk of wound problem, or why are you beginning to use those? So I think well, we know that ankles have a higher rate of infection and wound problems than hips and knees, full stop, largely because it's distal, it's a watershed area, and there's poor blood supply to the ankle. And I was seeing a lot of patients with just poor skin and the poor soft tissue envelope. So and the separate issue was that our clinical nurse specialist also came from a background of having worked with negative pressure dressing. So there were several impetuses that led us to try it. And as with all these things, you do one and you see if you like it or not. Now, there's some technical issues that are, you've got to learn how to put them on. If you put them on under tension, then the negative pressure actually causes blistering around the outsides of them. So that's something that we learned not to do. And obviously we no longer do that. And we now cut them so that there's no tension under the skin. And as you do one or two, you suddenly found that it looked fantastic after a short while. The patients found them acceptable to use. And in fact, the patients liked it because they felt they were getting some additional thing that wasn't standard. So that was largely why. And we've done probably about 20 now, and we're just looking at the data now. But so far, the patients have found them acceptable, and the results have been good. Okay, thank you. And one for Dave now. I'm going to read this one. If you've seen intra-articular varus deformity with no tibial bone loss, where the deformity is definitely worsened by the calcaneum being in varus, do you ever do an MAS calc osteotomy before the ankle replacement?
Pretty much no.
Okay.
If I get the question right. So I'll start proximally and work distally. The calc osteotomy is a really easy thing to do at the end of the procedure to balance the ankle. and not always required. So I wouldn't do that at the beginning, no.
Okay, and another question from the audience here. Have you seen any problems with your tib post lengthening in varus, and how often you think that's necessary, and how do you assess whether you need to do it or not?
So have I seen any problems with the tib post lengthening? No. I think the concern is that you're going to turn your varus ankle into a flat foot. I think there were some great talks at BOFAS a few years ago talking about cutting that tib post in the varus ankle, and I think a lot of us are doing that more routinely now. How do I work out if I'm going to cut it or lengthen it? I think just having in your mind that it's part of your armamentarium for the varus ankle. So I wouldn't go in saying I'm definitely going to divide the tib post, but it sort of comes at the end of that algorithm. So if I've still got residual varus, particularly in that sort of more internally rotated ankle, and if I've got on the AP, the standing AP foot, that adducted talonavicular joint, I guess I'm kind of going in thinking that that's something I might do, but I'll look for it at the end of my medial release.
How do you decide about a medial malleolar osteotomy? Is that a preoperative thing, or is it intraoperative from what you're seeing as you're correcting, or is it, how do you assess when you're going to do that?
So I think on my fellowship, there was quite a trend for doing sort of shortening osteotomies of the lateral and lengthening of the medial. So that was sort of in my mind. I don't use it routinely. I think there's certainly a situation where you see significant remodeling of the medial malleolus, and when you correct your talus, you've just got a big gap down that medial gutter. And I have seen an ankle that's failed back into varus where it's just collapsed into that medial gutter. So I'm always mindful of that case. So the decision making, it's intraoperatively. If your ankle is anteriorly translated and internally rotated, as you reduce it back into the mortise, if you see a big bone defect, that's when I'll think about doing the osteotomy. And I think you have to make the decision about doing the osteotomy before you've peeled everything off the medial malleolus. Otherwise, you've just got a bare bit of bone with nothing stuck to it. So you need to make the decision, I guess, before you've done that, but not until then.
Okay. And I'll ping back one over to Andy now. So Tim Daniels presented a series of poor outcomes from deltoid reconstructions. Have you had any concerns about your deltoid reconstructions you've been doing? And kind of a supplementary question, do you do that through a separate incision or the same incision? How do you do those reconstructions?
So I think that there's a lot of analogy between the deltoid and the lateral ligaments, and I suppose I've got more experience on the lateral side. But what I've increasingly noted now is that often what happens is the ligaments pull off from the fibula, and you form like a fibrous layer over the fibula, just like you get with a peroneal retinacular avulsion. And so the tendons flip over forwards, and basically the fibula is just a fibrous structure. There's nothing attached to it. So increasingly now worked out the importance of actually removing all of that fibrous tissue, taking it right the way back almost to bone, and drilling holes in it, and actually creating a surface for any ligamentous thing to reattach onto. There's no point putting fibrous tissue onto fibrous tissue and expecting it to join. And I think a lot of the failures, especially on the medial side, are because exactly that happens. As it slowly pulls off, you just form a fibrous layer there. And then any repair that you do just doesn't attach because you're stitching tissue to fibrous tissue. So now that I'm doing that, what I'm finding is if you take the whole sleeve and put it onto fresh bone, then actually it can reattach and get and have integrity. I mean, after all, we often do a complete release of the medial side on the valgus ankle, on the varus ankles, a complete release. You take off the whole thing and they don't become unstable. So it's because it reattaches, obviously, otherwise it would be unstable. So I think, I guess I'm putting it down to technique, but then again, there are cases where the tissues are just so lax and so, and the deformity is so complex that you can't rely on just a soft tissue repair alone. So I suppose if you're doing a triple or you're doing a hindfoot correction and you do a deltoid, I think that they get better results. And I don't do these allografts though. I think if you've got to use an allograft, I'd probably bail out and do a fusion. But yeah, so I think it's, for me, it's come down to technique. But I've you know, to be honest, I've only done a handful of them and they've gone okay. I haven't had any fail yet, but I hear loud and clear that a lot of people that have tried them they have failed. But certainly I wouldn't do it without stabilizing the hindfoot and balancing the hindfoot first.
Yeah, okay, cool. So a question to both of you really, and there's a few coming through on the chat here about CT scanning and the fact that some CT scans are only going to the knee when you're doing assessing extra-articular deformity, and also where do we think standing CT is going to come into planning for ankles? Do you think that's going to come de rigueur? Like we now do long leg films and weight bearing x-rays and things. Kind of. Well,
I answered above the knee, and Andy can answer the standing CT.
Yeah, that's good.
So yeah, I think it's a good question, because you're right, it only does go to the knee, so that's an easy to answer. I get a long leg alignment film, and then with the prophecy, the patient specific instrumentation plans, you decide where your mechanical access is, and you decide where your implant's going to go. So if you've got a varus knee that you're going to leave in situ, but you want to put your ankle to the mechanical access up to the hip, then you get your long leg alignment view, you measure your angles, and then you adjust your plan that way.
Okay.
Yeah, I agree. I do the same. So often there is a difference, and we've published on that to show there's a significant difference of the two. With regards to standing CT, I think up until now you couldn't do it, so you could only do the knee, and hence for me it didn't have utility. But actually now there is a scanner coming out from Curve Beam called the High Rise, which has only literally just been launched. And that will scan a standing person from their hips all the way down to the ankles. And I think that's going to be a game changer. So I can see the day when the hip and knee surgeons are all using that as well. And then you can actually look at the mechanical axis in both planes and in 3D. And I think then it will have utility, because we'll start to understand deformities that I don't think we do understand. We're interpreting deformities based on 2D imaging, and it's been very difficult to date.
Okay, great. Another one coming in here. So are there any factors in deformity that would push you towards using a primary implant versus a primary stemmed implant? I suppose they're talking about an Infinity or an Exact Tech advantage over an in-bone in terms of helping with deformity correction.
So for me, it's very, very simple. I don't believe that a stemmed implant deals any better with deformity than a non-stemmed implant. So for me, the only time I would use a primary stemmed implant is there's no distal bone. So if the tibial metaphysis is a void of bone, then I'd consider a stemmed implant. But otherwise, I don't see any role for a stem to deal with the things that we've spoken about in these talks. I know it's been proposed, but I can't see any logic in why a stem has any difference when you've got to balance the ankle proximally and distally.
Yeah. So I sort of agree with Andy. I think my experience is with the in-bone Infinity, so I can talk on that. So the articulating surfaces or the constraint are the same with both of those implants. So what we're talking about is fixation. So it's about that tibia bone interface surviving. So the only reason to stem for me on the tibial side would be if there's poor bone. So I did an in-bone primary last week for someone who on the CT scan, the distal tibia was full of cysts, and actually had to put 3 stem pieces in order to stop it from moving. And then there is one of the considerations is if you have a very stiff hindfoot, like a triple fusion and soft bone on the tibia, that stiff hindfoot is going to put additional stresses through the implant onto the tibia. So that's a consideration. Although I haven't seen an issue with my resurfacing implants and triples to date.
Yeah, that's good answers there. So kind of jumping back a bit, Andy, you mentioned about the the agility fusing the syndesmosis, and you thought it may be something to consider in a valgus ankle. Do you primarily fuse any syndesmosis in valgus ankles?
Yeah, so what I do now is I do the ankle replacement, leaving it alone. I mean, for most of them, you put it in and the whole thing feels stable and you get out at the end of it. The only time that I would do it is if once you've put it in, it's drifting into that space laterally. Okay, you've put your implant in the right place and it's drifting laterally because there's no buttress laterally, and those I'd simply just extend up, take the syndesmosis down, and put 2 screws across it.
Okay, and when you're doing your rostrums, do you do that through the same incision, a separate incision?
No, almost always do it from a separate incision. I think you can't appreciate where the ligaments are if you're coming from the front. So would almost always do a separate incision, curve just at the front of the fibula, coming down, a standard approach to that, and then you can get a beautiful view into the gutter. As Dave said, all those osteophytes have to come out, and then, as I said before, you've got to freshen up the fibula, because if you've got a sleeve of we did someone very recently, a young girl with Ehlers-Danlos loss, and all the structures were there. They were just all very lax. They weren't attached to the fibula at all. So you could pull on them proximally over the fibula and they just glided, and you pull them distally and they just glided. And then all we ended up doing was attaching the proximal ends back onto the fibula and then doing a standard rostrum. And she's done very well from that.
So Dave said he doesn't do many prostrums or lateral ligament repairs. You say you do quite a lot. So who's going to win the count back on this one? Why is there the different approach, do you think?
I think time will tell, won't it? So I think we're probably coming slightly from the same position in that I'll take all the osteophytes off that distal fibula. So I've taken all the bone off, and I guess my belief is that all that ATFL and capsular tissue is going to heal down in my implant that's already relatively stable because of its constraint. And I put my ankles into a back slab for 2 weeks. And then I get them into a boot, but starting some flexion extension from 2 to 6 weeks. So I'm not running these guys out straight away. So we'll find out 4 or 5 years, Andy.
Yeah. And a question here from the audience is, how would you address a valgus OA ankle with deltoid deficiency that is really a stage 4 planar valgus foot? So I suppose you probably answered that one already in terms of stage reconstruction.
Yeah, so do a stage reconstruction and decide, usually at the end of the first stage, whether or not the deltoid is completely gone and whether there's any chance of recovery. Most of the time, actually, the deltoid hasn't completely gone, it's just lax. And then I do that. And the answer to the question is I go through a medial approach like I would for a normal medial deltoid reconstruction. So it's a separate incision. Because you get much better view, much better clearance. If you come from the front again, then you can't quite see around the back where the tib post is.
Yeah. Okay, I mean, we're coming to the last few minutes now. There's any more questions to the audience? I mean, it scares me hearing you two talk because I'm worried about some of the ankles I've done and whether I've looked at them correctly or not. And certainly, I've appreciating more and more deformities at various levels. And I think I'm quite excited about standing CTs and hip and knee, but I think that's going to make our decision-making process even more difficult. And I think what you're demonstrating is, I think deformity is becoming less and less of an issue, as we keep on saying. It's all about balancing that foot, balancing the ankle, and getting a stable platform for that ankle to work through. So we're kind of drawn towards the end. Any other points you two want to raise for the audience to think about?
Just to clarify this issue of soft tissue balancing, we're talking about balancing, and I think, as Dave said, we're probably talking about the same thing, is that what you're trying to do is get soft tissues to attach back onto their normal native structure. And so by taking off all those osteophytes, especially on the ones on the front of the fibula, you're allowing the soft tissues to reattach onto it. But I think the key bit for me is that with hips and knees, well, with knees really, because
hips is a ball in a socket, but with knees, you know, the generation of evolution was bony cuts, learning about bony deformity, and then it became all about soft tissues. And I think we're now in that era with ankles that this is all about soft tissues. Osteophytes for me are just like they are in a hip. They fill a void, they fill a space. And when you've got lateral ligamentous instability, that's when the talus drifts over, you wear away your medial malleolus, and the gap that's sitting there fills in with bone. And so, you know, ultimately, if you're going to balance it, then those ligaments must have been pulled off at some stage in the past. And whether you're attaching them formally, as I'm saying that I do, or whether they're indirectly reattached, doesn't really matter. The key bit is that you've got to get a balanced, stable ankle at the end, and always worry about the subtalar joint, because that's something that we haven't talked about. You cannot fix a deformity below the ankle at the ankle, and you can't fix a deformity above the ankle at the ankle. And I think that's the key message from my side.
Thank you. So I think we'll get some feedback from the audience here. Thank you for two very clear talks with some good algorithms and what is a minefield of ankle replacement surgery. And I'd like to say to the audience, if you'd like to fill in the questionnaires, you'll be emailed after the talk. You'll be sent a certificate. It is does carry 1 point for CPD, and we're trying to develop these programs over time with EdCom and SciCom. So feedback is always appreciated, so we can improve the offering we give you. So I'll hand over now to Exact Tech. Say thank you very much then for sponsoring this evening's webinar, and look forward to seeing you all in person one day at a BOFAS AGM. Good night for the moment.